So, very good morning, everyone. Hope you are doing well. My name is Dr. Mazhar Galvi. I'm a practicing endocrinologist. Me and my colleagues, Dr. Hia and Dr. Melmurugan, are starting a new series of lectures which will help you in preparation for your MRCP exam. Initially, we'll be starting off with the MRCP Part 1, and then subsequently, we will widen the horizon to cover MRCP Part 2, as well as subsequently MRCP basis exams as well. So, in this series of lectures, we'll try to cover the high yield questions or the high yield topics which has appeared in the previous past exams. Because as we all know in MRCP, there is a lot of questions which are repeated and a lot of question themes which have been repeated from the past papers in the past exam. So we'll cover several important topics specialty wise. So let's start with rheumatology part 1 and wish you all the best and hope you all benefit from this lecture series. Let's start right away. So in question number 1, we have a 70-year-old female who presents to her family practitioner with a 9-month history of exertional left knee pain. She has BMI of 31. She's type 2 diabetic and hyperlipidemic. She also takes metformin plus SGLT2 inhibitor. She takes empagliflozin plus metformin combination. And her recent HbA1c seems pretty stable at 6.7%, which is 49 millimole per mole. On examination, there is crepitus when examining the left knee. There is no swelling as such. So given the most likely diagnosis, what is the most appropriate initial step? As we all know, in MRCP Part 1, we'll always be getting what is the most appropriate investigation, what is the next best investigation, what is the most appropriate initial step. So the options here are topical ibuprofen, oral codeine, oral ibuprofen, oral paracetamol, intra-articular steroids. So choose one of this most appropriate answer in terms of guidelines as well. So first of all, about the diagnosis. So you can clearly see it's a female patient. She has exertional left knee pain. She has metabolic syndrome, and she has crepitus when examining the left knee. So all this points out to a diagnosis of osteoarthritis. You're right. And this is the most likely underlying cause here. So what the best and the most appropriate initial step will be topical ibuprofen. So A is the correct answer here. This comes from guidelines which were published by NICE in October 2022, covering for the osteoarthritis in patients over 16 years of age, looking at the diagnosis and management. So all patients should be offered help with weight loss, given advice about local muscle strengthening exercises and general aerobic fitness. If we look at the step-by-step therapy, if needed, alongside non-pharmacological treatments, aid for exercise, that is what we mentioned, aid for weight loss, offer a topical non-steroidal anti-inflammatory drug or a topical NSAID, which is the topical ibuprofen in this option, and that would be the first choice. Then consider an oral NSAID if topical medicines are ineffective, so that would be the second step, or unsuitable, and offer a gastroprotective treatment alongside. So in that case, we will need to give a patient a PPI if you're going to offer a patient oral NSAID. Do not offer paracetamol or weak opioids routinely unless used infrequently for short-term pain relief. All other treatments are found to be ineffective or unsuitable. Then in that case, we can use on and off these things. Again, do not offer the patient glucosamine or strong opioids or intra-articular hyaluron injection as per the guidelines. Consider intra-articular corticosteroid injections for short-term relief when other pharmacological treatments are ineffective or unsuitable, or to support the therapeutic exercise. Again, this has been asked in the previous year. So this is as per the guidelines, extremely important for you. That was the answer. Moving forward, question number 2, we have a 29-year-old woman referred to the hematological clinic for investigation following 3 second trimester miscarriages in the last 5 years. She also has intermittent joint pains. I mean, most of you all have already started to guess the diagnosis here. She also gives on and off history of headaches precipitated by loud sound. Her blood pressure seems fine, BMI is 24. So basically joint pains, intermittent joint pains, history of repeated second trimester miscarriages, history of headaches. Then this is the biochemical picture, hemoglobin 129. We can see thrombocytopenia, white cell count seems to be fine, creatinine seems to be fine. So what is the next appropriate investigation in this regard? Is it anti-Rho antibody? Is it phospholipid antibody? Is it hysteroscopy? Is it VWF? Or is it prothrombin time? So by now we have the diagnosis, which is SLE, and that is causing the antiphospholipid syndrome. And that's why the correct answer is antiphospholipid antibody. So 30% has positive antiphospholipid antibodies in terms of SLE. In this scenario, they mentioned prothrombin time, but APTT is generally what is prolonged. There is an increased risk of thromboembolic events. There is increased risk of recurrent miscarriages. So that's how we diagnose antiphospholipid syndrome. In this case, it is secondary to SLE. Patient is having intermittent joint pains as well. Other options ruled out is anti-Rho antibodies. These may be associated with SLE, but generally we'll have other things mentioned like a neonatal heart block. Again, hysteroscopy may be used in patients for recurrent miscarriages to exclude congenital or acquired uterine defects, which can lead to fetal loss. Prothrombin time doesn't really come into question here because APTT, which is prolonged. The VAWF factor can lead to increased risk of disease in VW disease, but usually it is an autosomal dominant pattern, which is not seen in question. So, for diagnosing of an antiphospholipid syndrome, this may occur as a primary condition or may occur in the setting of an underlying autoimmune disease like SLE in this patient question stem. Other manifestations may include thrombocytopenia, which has happened for this patient. There may be skin manifestations like livedo-reticularis. There will be cardiac manifestations like lip band sac endocarditis or even renal disease. The diagnosis requires at least one of the two clinical criteria and at least one of the three lab criteria to be met. Clinical criteria wise, one or more of otherwise unexplained venous or arterial thromboembolic events or pregnancy miscarriages, as is mentioned after 10 weeks of gestation. So definitely our patient is satisfying one of the criteria. To diagnose further, we need the antiphospholipid antibodies, which is the anticardiolipin or the lupus anticoagulant, let's say, and that's why we need to get the diagnosis of antiphospholipid syndrome in context of SLE for this person. One more important thing mentioned in the guidelines, in the criteria, is one or more of these antibodies must be present on 2 or more occasions, at least 12 weeks apart, to give us the final diagnosis. Of course, if the patient is asymptomatic, but the patient is pregnant, then the patient will need low dose aspirin or low molecular weight heparin. Anticoagulation with warfarin may be required for acute thromboembolism, and if there is a catastrophic situation where there is a DIC or multi-organ failure, then this needs to be treated. Anticoagulation, glucocorticoid, and in severe cases, even plasma exchange and or IV immunotherapy. Let's move forward. Which of the following is associated with which of the following is not associated with poor prognosis in rheumatoid arthritis? Is it HLA-DR4? Is it RA factor being negative? Is it anti-CCP antibodies? Is it rheumatoid nodules? Is it insidious onset of the disease? So again, which of the following is not associated with poor prognosis in rheumatoid arthritis? So correct answer here is RA factor being negative. That's not associated with poor prognosis. So what are generally associated with poor prognosis in rheumatoid arthritis, clearly mentioned in the NICE guidelines published in October 2020, and also in the American College of Rheumatology guidelines. The poor prognostic factors mentioned are a rheumatoid factor being positive, presence of anti-CCP antibodies, poor functional status at presentation, X-ray showing evidence of early erosions for less than, with the disease onset of less than 2 years. If there are early erosion seen, then that's a poor prognostic factor. Extra-articular features like nodules and HLA-DR4, presence of HLA-DR4, and even insidious onset of the disease, all of them are poor prognostic factors. So clearly, the one which is not associated with poor prognosis is the RA factor being negative. Question number 4, we have a 63-year-old man presented with erythematous swollen first metatarsophalangeal joint on the right foot. This is causing him considerable pain and is even having difficulty in walking. He has never had any previous similar episodes. His past medical history includes atrial fibrillation and type 2 diabetes, for which his current medications are warfarin, metformin, and simvastatin. What is the most appropriate treatment of this episode? Is it prednisolone? Is it intra-articular corticosteroid? Is it ibuprofen? Is it colchicine? Is it diclofenac? So try to solve this question. Again, most of you all have guessed the diagnosis by now. The diagnosis is looking towards being gout. Now, take into context what is the patient on. He's currently on warfarin, metformin, and simvastatin. So what is the most appropriate treatment of this acute episode of gout? Correct answer from the option provided is colchicine. This is based on NICE guidelines published in June 2022. We offer a non-steroidal anti-inflammatory drug or colchicine or a short course of steroids for the first-line treatment of acute gouty flare, taking into context the person's comorbidities, co-prescriptions, and preferences. So we definitely see that the patient is on diabetic. So prednisolone will not be a good choice because that can worsen his diabetes. What about diclofenac or ibuprofen? So take into context that he is on warfarin. So if we add another NSAID, there is an increased chance of GI bleeding. So that pretty much leaves us with the options between intra-articular corticosteroids and colchicine. But if you see, as per guidelines, first line is use an oral NSAID or colchicine or a short course of oral corticosteroid for the first line treatment of gouty flare. But we cannot use prednisone because the patient is diabetic. So ideally, the choice will remain between colchicine and oral NSAID, but oral NSAID again might increase the risk of bleeding because this patient is already on warfarin. Consider adding a proton pump inhibitor for people with gout by taking an NSAID to treat a gout flare. Then comes the, you can say, a second line therapy. Consider an intra-articular corticosteroid or intramuscular corticosteroid to treat gouty flare if NSAIDs and colchicine are contraindicated, not tolerated, or ineffective. So even though intra-articular corticosteroid is an option here, it will come a second line. First, we have to look for colchicine, which will be the best and most appropriate treatment for this gouty episode, which the patient. Do not offer an interleukin-1 inhibitor, which is anakinra, to treat an acute gouty flare unless NSAIDs, colchicine, and corticosteroids are contraindicated, not tolerated, or ineffective. And refer the person to a rheumatology service before prescribing an IL-1 inhibitor. Advise people with gout therapy that applying ice packs to the affected joint in addition to taking prescribed medications may help alleviate the pain. Question number 5, we have a 32-year-old female presented with 3-month history of joint pain and swelling affecting her fingers, wrists, and elbows. Symptoms have been persistent and have failed to respond to oral NSAID. She is presented to rheumatology clinic and has the following investigations: RA factor positive, anti-CCP antibodies positive. So clearly with joint pains, not responding to oral NSAIDs, with RA factor positive and anti-CCP positive. By now we have the diagnosis in mind. So again, given her likely diagnosis, what is the most appropriate initial treatment to halt the progression? Options are steroids, methotrexate, allopurinol, sulfasalazine, hydroxychloroquine. Correct answer is methotrexate. This is based on rheumatoid arthritis guidelines published by NICE in October 2020. NICE recommends DMARD like oral methotrexate monotherapy plus or minus short course of bridging prednisone as the first line. So oral methotrexate is the most widely used disease-modifying antibiotic agent. Monitoring of full blood count and electase is essential due to the risk of myelosuppression and liver cirrhosis. Other important side effects to be kept in mind is pneumonitis. What is the other option which can be used? Sulfasalazine. Other option, leflunomide. Other option, hydroxychloroquine. However, hydroxychloroquine should only be considered for initial therapy if there is mild or palindromic disease. So that's the end of the session today. Hope you liked it. If you wish to listen to many such lectures, please subscribe to our YouTube channel, and that will help us support the journey of passing the MRCP. Thank you so much.